You're listening to the Physio Matters podcast in association with Choose Health, and this is session 6. Welcome back to the Physio Matters podcast. As per usual, I'd like to thank you all for listening and for spreading the word about our work. The reason I keep repeating it is because I don't stop being appreciative. When first launching the podcast, one of the areas in which we decided to publicise what we were doing was the realm of Twitter. And since we've had a chance to study the statistics and do some questionnaire research, we now know that only around 35% of our listenership are on Twitter. And if Physio CPD is what you're after, which I imagine it is if you bother listening to us, then I can highly recommend Twitter for access to some leading names in the industry, including all of our previous podcast guests. In my own journey on Twitter since the podcast launch in December, I've interacted on a number of occasions with today's interviewee, Seth O'Neill. Seth is a physio who seems to have found the rare balance of clinical work, undergraduate and postgraduate teaching, as well as academic research. Despite his hectic schedule, he remains one of the most generous contributors on Twitter, so be sure to follow him at Seth O'Neill. Seth is currently on with his PhD, looking at the Achilles Tendon and rehab of it. We have a podcast lined up later in the year in which we plan to discuss his work in greater detail. However, we don't want to taint his masterpiece, which will be published later this year. So today we talk about Achilles tendon more broadly and posterior ankle pain generally. We also brave the difficult discussion around tendon pain. So without any more from me, let's get to it. Hi Seth, welcome to the show. Would you like to introduce yourself?
Yeah, thanks very much, Jack. Thanks for letting me come and have a little natter with yourself. I'm Seth. I'm obviously a physio, as you guys know, active on Twitter, hence doing this talk at the minute. Started a PhD 2 years ago on tendons and have a little bit of a passion for tendons. Lecture at Leicester University and Coventry University. And have really done so for the last 8 years or so, and have qualified, I think, year 2000, so 14 years into my physio career now, and still enjoying every minute of it.
Brilliant. And why tendons then? What made you develop a passion for those?
A little bit of one of my mentors, really, when I was back in the hospital. So I used to work in the NHS in Leicestershire. And Rich Wood, who's recently joined up Twitter, used to be one of my mentors when I was in sports and med. And it was really good. We used to see a lot of tendons, and it was around the same time that eccentrics came into the fold. So started to use it a lot in actual clinical interventions and get to understand a bit more about what we were doing. Although obviously we've probably moved on a little bit since eccentrics were then the gold standard. Although probably still the most common clinical intervention at the minute. Yeah. I had tendon problems myself as well, though, right. So that's the other side of it. So I've had a peritonitis and a normal mid-tendon disorder. So
right, okay. So that almost does cue you up into an interest, doesn't it, when you've got to look at yourself? And so we will come on to eccentrics later on. We can't avoid that. However, why specifically did you then develop an interest or start to pursue the TA specifically?
It's always the one I was most interested in, and also the one that I actually saw most commonly in the clinic that I was working in, both in the hospital and obviously with my private work now as well. So it seems to be the most commonly affected, and probably the one that we had a bit more literature around as well back then. So there's quite a lot around lateral epicondylar stuff, but I always think I've probably picked the easiest one. The Achilles is more straightforward, a bit more sort of one tendon with two muscles attaching into it, whereas if you look at sort of rotator cuff or lateral epicondylar, it's a lot more complex. So I've picked the easy one to make it easy for myself, like right. Simple things.
Okay, and the fact that it is a more simplistic area, shall we say, that doesn't necessarily mean it's something that has been pursued and explained more than others. It's still, there is some degree of mystery, still a lot of understanding to be done. And why do you think that might be if it is the simpler one?
Oh, damn, hard question, that one. I don't think we've been necessarily looking at tendons in the right way at the moment. We've tended to focus on tissue pathology, which has now been shown to not really be the way forward. So I've always focused on collagen and collagen disruption instead of focusing on other elements that might tie in, like the neuromuscular components and also pain perspectives. And the literature has now started to sort of examine that a little bit more, especially with the group from Monash, So people like Ebony Rio and Jill Cook and the guys over there. So they're getting some interesting stuff out now.
Right, brilliant. And we will come to that sort of mismatch, and it's a mistake almost that's been made historically that we might continue to, but we'll chase that a little later. To talk about the TA more specifically for this podcast, if we start thinking, are there any key subjective questions or markers with a patient that's presenting with, say, query Achilles tendinopathy that you might go for?
Yeah, I'm quite simple in my clinical reasoning, and most patients, if they come in and tell you they've got an Achilles tendon disorder, probably 98 out of 100 will have an Achilles tendon disorder, to be quite frank. A lot of the guys like finger pointing, so they'll come in and either grip around the tendon or point to the tendon directly. And to be quite honest, that seems a good clinical indicator, whilst the research might not necessarily back it up in terms of sensitivity and specificity. If we look at some of the pain-free population, because they occasionally have similar things, it does seem to be a good clinical rule. In terms of other subjective features, you're really talking around pain after having sat for a while and then getting up. So they get sort of like a stiffness, they describe much like you will with back pain. And they also get stiffness in the morning is one of the common features. So get out of bed, hobble around, and that will take anything from a few steps to an hour, depending on sort of what stage the tendon's at. So there are some of the big things, and really the main subjective marker for us is pain during tendon loading or after tendon loading. I think that's one of the other critical aspects to understand, is that the pain doesn't always occur actually whilst the person's, let's say, running, which is where the majority of my work's in. It can be the aftermath, so the next morning or the next day that they're actually sorer. So tendon loading is really critical. If they're getting it doing something that doesn't really require stretch shorten cycle, so energy storage, then it may not be a tendon disorder that we're dealing with. Right,
okay. And the latency of the symptoms, is that something that's sometimes maybe not chased as well as it could be?
Yeah, I use good old-fashioned sin factor and actually look at looking at severity, irritability of it. And the irritability is really that aftermath element of, well, how long does it take to either come on during the activity, or how long does it persist for afterwards? And just go for good bog standard basic physiotherapy terms like that. If we look for latency, I think that can allow us to work out possibly how much of a central mechanism is going on compared to a purely maybe peripheral nociceptive disorder. And it's something that doesn't really seem to be discussed in tendons that frequently. It was a little bit of what sort of came into some of the work we've been doing, but obviously it's now really hit the headlines a bit more. There's been a few papers coming out on central pain processing, both in tennis elbow, a systematic review by Heels and Vincenzino in BJSM, and obviously Ebony's work from Australia as well coming out. So there's some good stuff. We'll ask a little bit about any swelling as well, but some patients will notice it, some won't, and some patients won't have any actual size change to the tendon. Notice I've said swelling and not inflammation, because obviously we're not talking about an inflammatory disorder here, we're talking about edematous changes within the tendon. But yeah, they're the key subjective markers from my perspective, really.
Okay. And so in terms of, shall we say, differential diagnosis of that area, let's say posterior ankle loosely, what are the less common, particularly less common than TA tendinopathy, sort of masqueraders, if we think about the non-mechanical ones and the mechanical ones?
Yeah, we can get a whole spectrum of stuff, and I tend to, again, go very much... forget the pain science for a moment and just think of structures that may cause the symptoms in that area, and literally think, well, we've got a couple of nerves, so sural nerve and tibial nerve, both possibly able to cause symptoms around the tendon. We've got a few of the tendons there, so perineal tendons and tib post, a little bit further forwards, obviously, but around the same region. We can pull in plantaris into it, but we probably consider that still a mid-tendon tendinopathy, but just a compressive aspect on the medial side. And then we have the bursitis issues, where you might have a frank bursitis, so looking at either of the two bursa in the region, so subcutaneous or the deep one. However, the tendon sheath, the paratendon, actually encompasses the bursa normally, and possibly the fat pad, according to some literature. So if we're considering fat pad disorders as well, we really might have to consider it as a tendinopathy, but just involving different aspects. That is something that really nobody's examined and gone into that much. And certainly in sports med, where we used to work, they just inject them, which I think seems to be the general consensus. is if you've got a definite fat pad disorder, they'll tend to have a corticosteroid injection and try and sort of settle it down. If it is in the paratenon and you're injecting in that and popping the corticosteroid in there, maybe a little bit of an issue with that in the long term as well. So something to be cautious about. Other things that might cause symptoms really then are posterior ankle impingement. So looking at either bony or soft tissue impingement at the back of the ankle, but you'll normally get a different set of subjective factors. So it'll be time spent in a plantar flexed or end range plantar flexed position, probably looking at ballet dancers or fast bowlers in cricket. Not something we tend to see that often in runners. Having said that, though, I did have a chap who turned up a few weeks ago and said he had an Achilles tendon disorder, and it was been treated by somebody else as an Achilles tendon disorder, but actually was a posterior impingement of the ankle joint. So yeah, they're the main sort of things you're really going to come across, is the other tendons, the other nerves possibly causing pain there without the full neural stuff. So they're not necessarily going to have pins and needles and numbness and burning pain. They might just have a vague ache, and you're only going to pick it up by doing some neural dynamic testing.
Do you think that there's, is there any particular, not necessarily sinister, but lesser common, more serious pathologies that we need to just be mindful of that are rare but important?
Representing as Achilles pain, probably not all that frequent. Stress fractures are a possibility, but you're normally going to get an anterior stress fracture in the tibia, or potentially distal fibula. So possibly some bony tenderness that you might need to look for. But again, the site of pain tends to be quite localized. They tend to get quite a nociceptive drive. It's mechanical rather than any of the central mechanisms that we tend to focus on. I guess there's some chance of some soft tissue tumours and stuff, but the vast majority of sarcomas and things I've ever seen have always been in the thigh, occasionally the knee, some of the bony stuff, but tend not to see anything really in the foot and ankle that I've come across, especially not in the posterior foot and ankle sort of region. So,
okay, doc. And do you think that things like vascular risk factors or anything that, in that sense, we see a lot of people that are query DVT or something like that? Is that something that you necessarily see, or something to be even mindful of?
Yeah, vascular risk factors are an interesting one. Roger and Alan, as we discussed earlier, I've wrote a paper with them a while back on popliteal artery entrapment syndrome in a patient that had been referred for a calf strain. It's quite a common presentation, but it's something, thankfully, we don't see that frequently either. But it can happen in young people, but it will tend to give posterior calf pain and claudication type symptoms rather than localized ankle symptoms or Achilles symptoms, in my experience of it. And the same goes for DVT. You'll tend to get profound swelling, the usual sort of features we look for, some venous engorgement, become hot and edematous, but higher up, and they will probably have some of the other risk factors that you can see sort of Rogers and Alan's work for, really. Brilliant.
So it's not quite as a difficult, subtle thing to look for. It can be quite obvious.
Blatant, obvious things.
Yeah. No, that's great.
The big obvious thing is how I do my clinical reasoning and stick with the basics.
Lovely.
Do the basics well.
We have naturally started to touch on it, but are there any key lookouts for these things, both subjectively and objectively, would you say?
Yeah, it's just moving it forward. So if you're looking at the stress fractures and consider sort of calcaneal stress fractures and the tibia and fibula, it's really looking for weight-bearing induced pain, increases in training threshold, and load-bearing pain that's specific, and they're often point to the bone to sort of discern that. And again, all of your other musculoskeletal assessment would be negative. So you do all your soft tissue screen and things, and it'll all turn out to be clear and pain-free on testing. If we're looking at the bursal stuff, you tend not to see obvious swelling like you might do around the knee. You're just going to have localized pain over the insertion or just deep in there. And sometimes the pain might be in a dorsiflexed position. So if the person tends to sit with a foot bent underneath them, so their knee's quite flexed, sometimes they'll complain of that being the predominant feature, because that's actually going to compress the bursal a little bit more. Or actually wearing footwear that compresses it. And they'll say, if I put these sandals on and stuff, it feels much more comfortable. And certainly that's been my experience when I had a peritonitis, was I just wanted to be out of normal shoes. Trainers were not too bad, but getting out of shoes was much more comfortable. Popping their sort of flip-flops on and stuff like that was great. So that sometimes will be your bursa. The other tendons, they'll react in a very similar manner to how your Achilles will. So I have the same sort of pattern, both subjectively and objectively. And then the neural elements, really difficult to pick up, actually, I think, because often they're sort of, I think anyway, is how I sort of think of it in my simple head, is a little bit of a friction sort of disorder, and maybe getting adhered against some of the tendon or within intramuscular elements. So often, if you read sort of Roger's work and Alan's work on the vascular elements, they're normally down to little accessory slips of the muscle. And I think the same probably happens in the nerve tissue. And if you think of popliteal artery entrapment, well, if the artery is getting squidged, surely we must see neural entrapment in that same zone, but we perhaps don't pick it up in the same way.
Yeah.
So my objective testing will always include a straight leg raise, coupled with bias in it to look at the sural and tibial nerves just to see if they are symptomatic. So we'll add the dorsiflexion on, add the relevant inversion or eversion, and then we'll do the actual hip movement and look if that reproduces their sort of Achilles area pain. If it does, then I think we can say, well, we seem to have some neural component to it. Whether it's all or nothing, I don't know, but that's your clinical reasoning bit. So,
well, of course, yeah, it becomes broader than that, doesn't it? And it's just the start of a detective journey. And if say you were to discover that there was this neural component, neurodynamics aggravated the symptoms that were theirs, pursuing that, if we were to think that it might be some adhesion that might not be sliding well, okay, that's a word that someone might then chase. Well, let's fix the local adhesion and start going to town on potentially getting stuck in there, whether that be manual treatment or others. Is that something that, would you stay that local, or would you treat that more broadly?
I'd probably do a bit of both, to be quite frank. I know people don't often like local treatment. It seems to be sort of a bad word in physio at the moment. But if we're thinking of neural changes and if we are going to say the nerve maybe is adhered down and not sliding through, so it's gunked up is often the term I use with patients to keep it low-key and non-threatening. Yeah. Then, some specific soft tissue mobilizations in and around the calf or Achilles may well do it, because we should be mobilizing the container, as people call it often in nerve terms. And then tying in just some global movements as well. But if it was as simple as just doing the global movements, surely their running would have solved that in the first place. So that's why I think sometimes you have to look at the tissue itself and do something locally.
No harm in bringing it less functional in inverted commas.
I don't think so. I think with a lot of the research we've been doing, we're looking at specific lab-based testing on Achilles, and function, the person looks all right, so they can run, they can do all right, it hurts them, they can do calf raises and do some other stuff like that. But if you stick them on the machine and do the testing, they're really, really bad, and they shouldn't be able to do those things, but they can. So what it tends to tell us is, in function, the person can compensate for a tissue issue. So I think we've got to be careful when we're using function sometimes in tendons, and I know Jill Cook will often talk about it, and she gives you examples of where they've had people with something like a Patellar Tendinopathy. They're really strong doing deadlifts and squats and stuff, but stick them on a seated extension and they can only sort of do a small weight. So things like that, I think we've just got to be careful, and we're not talking necessarily exercises that are pain inducing either here. They're doing the functional task and the weights sort of isolated muscle tendon test without pain as well. They're still terribly weak. So there's a lot to sort of think about, I think. So
the body's, it's clever cheat, isn't it? Sometimes we can always get, our body will naturally go around the houses as a way of just doing something. So that detective work that we talk about. More recently, there has been a real push towards a more specific differential diagnosis, even within the realms of Achilles tendinopathy. You've mentioned the bursa, even the fat pad, even the location of the portion of tendon affected. What are your thoughts and feelings on how that stands and how to integrate that into standard MSK practice?
I actually think it's quite important, to be honest. Mid tendons, we think anyway as a tensile load issue. So the tendon's actually getting sort of pulled from its insertion by the muscle and getting overloaded that way. And then if we think of the insertional disorders, we seem to have a fair bit of evidence that suggests it's a compressive element now. So you're actually having the sort of superior aspect of the calcaneum coming into the tendon as the person goes into a dorsiflex position. There's one RCT that sort of showed that doing an eccentric regime onto a flat surface rather than into dorsiflexion over a step was better. had a better outcome. I think it's about 60% or so got better as opposed to 30% when you just did it normally. So I think we can say safely that there are tensile tendon disorders, there's compressive tendon disorders, and we may even have compressive disorders related to the retinaculum. It's been talked about. How much of that comes into physical function-based ones, I don't know. I often think of that as some of the sedentary-based pathology. But until we start to look at the tendon in a bit more detail and potentially using some of the new imaging techniques, I think we can't say where in the tendons necessarily reacting to the load. So I think it's really crucial. And if it's a muscle tendon junction, I think timeframes are different as well. Right. We tend to see that, and it's been well talked about in the past, where we consider different healing stages for these bits. But we also know pain doesn't tie up with these healing stages, and so there's other elements we've got to consider as well, which probably comes into some of the central work that's coming out as well.
In a realm like most, which differential diagnosis is difficult, some like to argue that we need to be less specific. So do we need to be comfortable with being vague almost? Or is posterior ankle pain something that we can pin the tail on the donkey, so to speak?
I think we do need to be relatively specific with tendons. I think there's probably more evidence for tendons in how we can be specific. So if we thought of back pain, we don't like being specific generally, for especially the non-specific back pains. But we must remember there are specific diagnoses even in the back world, and people like Peter O'Sullivan will happily say that, and they're taken off and done certain things with. So I do think we've got to be specific when we can, and it will guide your treatment. So if we talked about posterior heel pain, and we're talking about a patient with a posterior impingement compared to a fat pad, compared to a mid-tendon tendinopathy, their response to loading-based regimes will be grossly different. And that's a big issue. If we use the patella as another example, patellar tendon, often people misdiagnose patellofemoral joint disorders as a patellar tendon disorder. And the response to loading is obviously very, very different. You load a PFJ problem, you'll tend to aggravate them and make them worse. Whereas if we load the tendon problems, they tend to resolve and recover well. So I think it's really crucial to actually subcategorize into various elements and try and then do it. When it comes to pure tendon disorders, so whether it's a compressive or a tensile, I don't think we've necessarily got full understanding at this minute. But we should still use some of that knowledge because it does guide our clinical interventions.
Of course.
So it's useful.
Lovely. And so with, if I just pick a couple of those things, and we say that someone is a desk worker that sits with their feet beneath them and go into that very dorsiflex positioning with a very flexed knee, and we say that would potentially be a compressive factor over the insertional TA, but also a compressive factor on the bursal tissue. And so would understanding which of those components in what ratio, would that be a game changer?
Not for me in that instance, if we're talking about a deep retrocalcaneal bursa, because we're talking the same pathology. The bursa's there for a reason. The tendon's getting squidged, the bursa's getting squidged, and we're talking about a sedentary person as well, so we're probably looking at other risk factors. So those risk factors might be things like obesity, looking at diabetes as well. So we're just looking at trying to desensitize the sensitive tissue, much like we'd look at the back pain aspects. However, if it didn't respond to conservative measures, a lot of people will look at popping a corticosteroid into it, which is a interesting sort of aspect, because we know the corticosteroids will lead to tendon degenerative changes and really sort of frowned upon by most. There's a few people that still recommend them, but they're looking at recommending a very short-acting corticosteroid instead of the longer-acting ones. So I think there's maybe scope. It's not something I do. I don't inject, and obviously I'm working privately as I do. I don't tend to refer on because I tend not to have people that need referring on, but maybe I'm seeing a less complex set of patients, and maybe I see less failed conservative management ones than some of the other big tertiary clinics will do.
Okay, yeah, we see each other. Sometimes we do see each other's failures rather than seeing each other's successes. But equally, it's a fine line and a tricky headache sometimes for clinicians to try and work out when to introduce things that you maybe can't do. Would you say, although we've touched on it, there is anything different to your objective assessment that we haven't touched on in this query Achilles tendinopathy patient?
We've probably covered most things. So we'd look at the normal sort of biomechanics of the lower limb and talk about the subjective loading elements. I spend about an hour with a new patient generally, especially on Achilles. I find that actually you do need an hour, which sounds like massive overkill to most people that are used to 20 minutes, 30 minutes in the clinic. And if all you're trying to do is work out whether it's an Achilles disorder or not, yeah, you can do that in sort of 10, 20 minutes. If you're trying to come up with a focused, specific rehabilitation strategy for them, you need that longer period because you need to get into the head. You need to understand the psychology of that person, and you need to try and sort of change that around. So there's a huge amount that comes into the subjective that's more akin to low back pain type assessment, right, rather than just the sort of tissue-based sort of sports med type approach that a lot of us have often followed. But yeah, the general of the tendon stuff will be looking at loading. So we'll look at some sort of muscle tendon unit function aspects, doing calf raises, doing some hops or jumps, depending on what they're doing. And we might even look at running if necessary as well, just to see what we can pick up. But really, I try and keep it sort of quite basic like that. As I said, I think a lot of people can hide their sort of muscle and tendon deficits very well in the functional tasks. So calf raises is a good example. The people in my research have been able to sort of eat them. They can do them all day. They're sort of like, they go, and this is easy, Seth. It feels the same on my right and my left leg, even though it's my right leg that's bad. Pop them on the machine though, and actually technically they shouldn't be able to lift the body weight. They're well down. They're sort of half the body weight and things. So we're getting very big differences with that. Which
presents a new challenge, doesn't it, in the fact that not everyone has the kit available. So
yeah, we need to come up with a clinical test really that mimics what we're doing in the lab. That's something that I'd like to work on a little bit later in either my PhD or afterwards. We need to try and sort of move it forwards from a clinical perspective, which is going to be a bit tricky, I have to be honest. And equally, whether we then need to change things that way, I don't know.
And when coming up with a loading profile for an athlete for rehabilitation, would you say that working on the feasibility of that in their psychosocial being, or how feasible it is that they're going to go away and do that, is that something that you feel gets missed and you look into personally?
Absolutely. Yeah, it's a huge part that seems to be often not talked about when we're talking about active athletic type individuals. We don't really look at sort of yellow flags like we'd screen for typical back pain, but they still apply. The person often has strange beliefs about what's wrong with the tendon in the first place. They understand it as an inflammatory disorder, and that's quite a big thing, because if they understand it as an inflammatory disorder, their sort of response to pain is then one of rest, and actually that deconditions the tendon and the muscle further, and is actually, I don't want to use the term harmful, but it's detrimental to them. So it will reduce what they can then do from a loading perspective. So it's always one of the first questions I ask a patient. So what do you understand is wrong with your tendon? And then just let them ramble on and tell me about it, and see what they've picked up on the web from running magazines, other runners, doctors or whatever. And if necessary, and normally definitely necessary, change that sort of concept that they have of understanding tendons. So I know when we talk about back pain, we don't like talking about tissue so much, but I do. I explain tendons as a tissue. I draw them a little diagram of collagen and talk about what happens in it and how the cells will go a little bit mad and produce some proteoglycans. I always just describe it as a small protein that sort of sucks moisture in, makes it expand a little bit, and that's what the swelling is. It's not inflammatory. It's not white blood cells or any of these other weird and wonderful stuff. It's your tendon cells going a bit mad because you've done too much exercise, letting you know that you've done too much, and they then need to be appropriately settled. So activity modification and everything else. The other aspect actually really with a lot of your runners is their hypervigilance as well. So they're really focused. So some patients might see you with a niggle that really is just a niggle. And a few guys that work in sports club will often describe this as your athlete will come in and say, "Oh, my tendon's hurting." And you'll say, "Well, how long's it been hurting for?" And they'll say, "Oh, 5 minutes. It's literally just started on the track." It's like, well, not really a problem. So that level of hypervigilance is sometimes an issue, and overly sort of aware of the body. So we have to sometimes then say, that's normal, you've done a bit more, we just need to settle it back down. So we just get you to take it a little bit easier tomorrow. And that might be sort of where some of this interest in UTC scan stuff, which is the ultrasound tissue characterization from Rosengarten, which was at the conference recently in Monaco. I think they've reduced their injury, I won't say injury risk, they've actually just reduced the number of injuries in the Aussie rules football, and they've used the UTC to sort of monitor tendon changes afterwards prior to symptoms developing. So there's some interesting stuff coming with actual tissue response might tie in with pain a little bit more there. Other aspects of the psyche that we need to consider in the runner, or I'll say runner because it just happens to be where most of my patients come from, or loading based stuff. It is fear avoidance. A lot of these patients are getting pain with loading, so their immediate response is to unload it. And obviously with tendons, we now know that actually they need load for tissue health and to improve the disorder, and certainly seems to be really the only good conservative measure that we have for tendons is to get the loading right. So that's a little bit of a reduction sometimes in terms of training volumes, but then it's specific exercises trying to condition the tendon and the muscle tendon unit.
Okay, and so when it comes to education and working out where to pitch it, we don't want to become, if we become too neurocentric and avoid tissue discussion, then we can almost miss the elephant in the room, particularly if that's something that the athlete wants to know about and discuss. But equally, we don't want to make them too hypervigilant on the integrity of the tissue. So finding that balance, not saying it's easy, but important in your eyes.
Yeah, really critical, and a lot of it's using snippets from neuroscience and pain science, and also from sort of typical physio type work, and trying to sort of put it together of, well, okay, this is going on in the tendon, it's swollen up, it's a bit puffy. We can talk about how that might link to some of the pain. Maybe we just need to sort of get you doing this right and settle things down, let the sensitivity settle. So we normally talk about it being sensitive or sensitized, which is sort of similar words that you'll hear most of the pain specialists sort of talk about is tissue sensitivity.
So I don't know if you'll thank me for it, Seth, but I'm going to ask, what do you think, or what causes pain in tendinopathy?
It's a good question. It's one that most of us would probably walk out the door with. I've got a few different ideas with it, and some of it comes down to pain aspects from back pain, and some of it comes down to some of the actual tendon stuff that we've got. I think one of the critical papers that people need to have a read of, or not even a paper, is William Gibson's PhD, which is freely available, and it's on DOMS, so delayed onset muscle soreness, but actually delayed onset soreness. So his PhD really investigated in a multitude of studies what causes pain when we get muscle soreness after exercising, but also looking at tendons at the same time. And the key finding really from his animal and his human work was that the thing that sources the pain seems to be the fascia, or what we often would call the epitendon or the endotendon, so the connective tissue layers, as opposed to the contractile fibers that we often think of with DOMS. Okay. And that was true of the muscle and the tendon aspects. Most of these studies were done on tibant, so tibialis anterior. There's a little bit done elsewhere. And they seem to show this. And so it opened up an interesting aspect, because if we think of DOMS, what's your typical defining factor? You have a person that does a bout of exercise, perfectly fine, to fatigue, who then ends up with sore muscle, or in their research clearly showed sore tendons the next day. And if we think of tendon pain, well, is that not just what we see with tendon pain? So are we seeing delayed onset soreness, which is actually the source? Yeah. So instead of disruption to collagen, we're seeing a reaction in the fascial components of the tendon. And this matches up with quite a lot of the research that shows that the peritoneum, in the Achilles case, has most of the nerves within it. Nerves don't tend to go into the tendon proper. So I do wonder really whether we're just describing tendon pain slightly inappropriately and we're talking about delayed onset soreness. Okay. There are differences, and those differences are due to collagen change, you'll get the vessels growing into it, and you'll get this sensitive both to mechanical and touch pressure, and you'll get allodynia, and hyperalgesia will definitely develop. We will routinely see that. And in many aspects, if we were seeing that in the spine, we'd term that central sensitization. And that's right. William Gibson's work again showed that the pain mechanism was one of central and peripheral adaptation in terms of sensitivity within the nerves. So I think what we're seeing is alterations in the central and peripheral system that make the area peripherally sensitized.
Yeah.
So when we load it, it then reacts faster and worse than it should. And the pain's not there when the person's at rest until they then move again, and then it seems to go. The best papers really to look at in this area are Ebony Rio's paper from Monash with Lorimer Mosley, I think, is the second author. It's gone around Twitter quite a lot. So
yeah, we can certainly reference to that in the show notes.
Brilliant. So that's a very good one. And then Heels and Vincenzino's central mechanisms they looked at for tendinopathy in BJSM. Good reading. Chris Littlewood's shoulder one that he's done as well, looking at sort of central aspects. Having said that, I think I said at the start, I don't think the only cause of pain is about this sensitivity there. I think there's other aspects that can protect the tendon or sort of potentially shield the tendon from those loads, and that then allows the desensitivity or the tendon to desensitize over time. But yeah, I do think we're talking sort of a little bit differently sometimes. We should maybe consider it as a delayed onset soreness type thing. And if we phrase it like that to a patient, they then start to understand it a bit more of, well, okay, if I just get the load right and I don't irritate myself the next day too much, right, we can start to load at this safe threshold that's not irritating me, like they would do for a muscle that they expect and anticipate. And they can then go through it there. And so you're nearly ticking off a few psychosocial boxes in the way of playing down what's wrong, giving some understanding about pain, and moving it forwards over time with loading.
That reassures them quite nicely because it's something that they know full well, regardless of whether someone's an athlete or more sedentary. They understand that if they overload themselves, they'll feel it the next day, and that's a normal process. And an escalation of sensitivity and perception of threat of the body and brain is a very normal process, as we discussed in previous podcasts. I know that's something that perfectly marries up the brain and body.
Absolutely. We also know really that loading, if we talk about delayed onset muscle soreness, loading makes you feel better. So if you've hurt yourself and made your muscles sore by going running one day, if you have a light run, a gentle run, it tends to make it feel better. And that's particularly what we see in tendons. And the focus really over the last few years has been into isometrics and looking at isometric loading for that. And again, the work coming out of Monash has shown that you can reduce the pain sensitivity for a period of time after having done isometrics. But it's not only isometrics. Concentric, eccentric, sort of isotonic work reduces the pain to the same level. The difference is when we talk about athletes is that seems to then make your muscles fatigue as well. So if you're doing it prior to performing or prior to doing something, you maybe don't want to do that. So we might use isometrics for the athletic individual, but we can use isometrics or isotonic for our Joe Bloggs person. And I tend to use a good mixture. I always thought the original Alfredson regime had an isometric hold at the top for a few seconds prior to doing the lowering. And isometrics has always been something I've been interested in. And if we think of other tendinopathies like the rotator cuff, isometrics featured really heavily in our typical physio teachings and training. And one of my last roles in the NHS was as a A&E specialist at Leicester. And we used to see these people that came in looking like they'd had a ruptured cuff. So pseudo-paralysis in their shoulder. And we'd test some of the muscles and they'd have sometimes positive lag signs or sometimes sort of semi-positive ones where you weren't sure. So you book them into a specialist clinic a few days or a week later, send them away doing isometrics, and they come back with full pain-free range of motion. And they just kick the muscle in. And in their history, they'd never had an acute onset. They'd often done something really heavy the day before, like hedge trimming or something similar that they only do once a year. And so that's where sort of my interest came to the isometrics with, but that work's been taken sort of loads further with the guys over in Oz, and it looks really interesting what they're doing. And it'll be interesting whether to see it maps out to the Achilles. I've had a few chats on Twitter and various places that some people have found it difficult with the patients, but it's at the end of the day with tendons and recovery, we're looking at time under tension.
Yeah.
So it's the time the actual tendon's loaded rather than asking it to energy store. And if we do isometrics, it's easier to get the time right, because we can say 45 seconds, you load it in that position. Whereas if we say do 10 or 15 reps, the length of time one person takes to do 10 or 15 compared to the next will be very different, and it's hard for us to dose it sometimes.
Okay.
But I do tend to just use reps and with a little bit of a hold thrown in. So it'd be really interesting what we do, because part of my work is to try and develop a new treatment regime for tendons. That's where all our basic lab-based work's lead into in the future. So that's something that we're hoping to sort of get out there as well.
And something that we plan to discuss at a later date, which I look forward to.
Yeah,
one of the things that people do jump to the defence of, especially when people like Chris Littlewood quite rightly will provoke a discussion about the central components or the continuum model not being particularly friendly in the way in which pain integrates into that, is that there is, unlike other body parts, whereby sensitivity can then provoke a smudging of the homunculus or a heterosynaptic spreading of symptoms. Sometimes people jump to defence of patellar or Achilles tendinopathy, saying, why don't we see that natural symptom spread due to chronicity? Where's that sit with you?
Yeah, I mean, it's been studied a little bit, and it just doesn't. You don't get that widespread sort of central sensitized response you'll get for back pain or some of these sort of more proximal joints. I think if we look at the shoulder, which is obviously where Chris's work is, I think you do see a wider spread, and I think you do for the hip. So Alison Grimaldi's work around the hip joint, I think you see it, and whether that links to the bursal elements, because they tend to have quite large bursal elements, and I think people like Angie Ferron have probably got work coming on that might be out later this year at the Tendon Conference. I think there'll be some interesting aspects, but part of me just thinks that the proximal base has a smaller homunculus area, whereas when we get into the periphery, like our hands, we know are quite big and our feet are quite well represented. So I just think it tends to sort of stay quite localized due to the distal components, but there could be the bursa and a few other things, and we've got to consider also nerve supply for actual tissue, that it's a bit more specific lower down, whereas around the hip, let's say, L4 might supply a load of different structures, whereas what it supplies in the foot or the leg is quite specific. So that might be part of it, but I don't really know, and I'm not sure anybody has a definite answer at this stage.
No, but to me it is nice that it's being discussed. It's something that there is an open playing field now for these chats to be had.
I think it's crucial. With my work we've done, I've used the fear avoidance beliefs questionnaire and modified it for the Achilles, and used that as part of my screening, and we're going to try and move that forwards as well. So there's a big place for central changes, but I think a lot of that's, like we talked about earlier, with sort of fear avoidance, the beliefs about what's wrong, and the hypervigilance, and reducing those aspects to allow the person to successfully load, which is what brings about the treatment response we want. I do think it's dose respondent as well.
Fantastic. So if we can, as things emerge, as long as we, for the first time in physio, don't get carried away on a theme, and we keep his mind open to other things, then it's only going to be positive.
Yeah, absolutely.
Okay, so yeah, it all does tie in, and people, they're bridging the gap, although not easy, is something that we're all working on in similar lines. And we touched on it again. It's flowing quite nicely into the scanning you have mentioned, and I'm interested from a personal point of view, and I know that people that have known I was interviewing you, I'll see what Seth thinks of this, is to scan or not to scan is often difficult, but could we be guilty of making the same mistake again as live ultrasound becomes more readily available? Could we be, because we're interested, are we doing it maybe a bit too much? Could we say?
It depends on how we sell it to the patient, right, or explain it. It's like all of our interventions, it's all down to us and the patter we use clinically. So whether we want to say metaphors or however we want to phrase it.
I'm sick of metaphors, yeah. Seth, honestly. I've heard that too much now.
That's very good. So, yeah, I don't have a scanner in my clinic. I've used a scanner for my research. I think scanning does have a place. I really do, because I think it does allow us to look at certain elements, but I think we've just got to be also careful with it. And part of people's problem with scanning really relates to this fact that your tissue pathology on the scan doesn't seem to correspond to your pain, which I guess is true. But we've got to think of it a bit more deeply in terms of if I've just ruptured my Achilles, let's say, that would clearly correspond to my immediate pain, but particularly my disability then. And we don't know of patients that can function with a totally ruptured Achilles. But the problem and the evidence most people use for scanning comes from the shoulder. And we know that people may have a ruptured cuff in certain aspects of it, but still function really well. And that's probably the key, is to distinguish between what area we're looking at. So with the cuff, I think the reason we can often get away with really bad imaging in terms of collagen disruption and still have good function is you've got the crescent and the cable up there, and it makes it far more complex. So if you sort of end up with a zone that's grossly degenerative and actually doesn't have any intact fibers anymore within supraspinatus, well, infraspin and a few of the other muscles may well be able to compensate and pull down. And we've got to also remember, and it's one of my sort of little pet bugbears on Twitter, is often when we're talking about the imaging and saying ruptures, people aren't really talking about ruptures. They're talking about a scan that has a zone of non-continuous collagen. Non-continuous is different from a rupture. Rupture's an acute situation like we talk about in the Achilles. But if I scanned an Achilles and this person has a gradual onset and it has a zone that doesn't have collagen within it or doesn't appear to have much fibers that are intact, that change is probably just degenerative. It's a tendinosis. So they've lost it. And if we lose it gradually like we do, we can probably find a way around it. So hence with the shoulder, you can have a zone that's non-continuous, not an acute onset rupture, but non-continuous gradual insidious problem that they function perfectly well because they've developed other muscle compensations.
Okay.
Maybe in some of the big movement muscles that actually overlie the cuff as well. Whereas the Achilles, it's a different kettle of fish.
Some consider, and particularly on Twitter, they might say that it's just semantics. Just because we're using the term rupture doesn't mean we necessarily mean break. But it is important, as we've known, that the language that we share with patients or with each other is important. And I think that's a really good point to make.
I do talk about wear in the tendon with patients, but I sort of phrase it that it's like your favourite moth-eaten jumper. You've got this little hole, you've never torn it, but there's no fibres there. But that can improve and repair. If we stimulate the tendon right, you can get some new fibres there. Now, technically, we might not be able to regenerate the tendon, and there's a lot of discussion going on linked to the study that was done using the carbon dating from the bomb that they used to use, and they looked at various elements within it. I sort of think of the tendon as a bit like your house. You might have damage to your guttering and your mortar, and it gets sort of repaired by us going outside. So that's like your tenocytes repairing little bits of collagen that have been damaged.
Metaphors there, sir.
Yeah, sorry.
No, don't mind.
It's one I've stuck on Twitter a long while back. But the house metaphor for a tendon, I think, works. But I know a lot of people hate that and they don't think that's accurate. But I think it plays it down from a patient perspective. Well, look, you get this bit of wear. It just needs to repair that little bit.
So whether scanned or not scanned, there is that element of reassurance regardless of the imaging, and you don't hang your hat on the image, in your opinion.
Yeah, I don't at home, and I don't feel like I need to or I miss out. If you can, I think it's a luxury, and if it's sold and discussed to the patient in the right way, potentially very useful. Now, that's normal ultrasound or MRI imaging. If we then go into the new ultrasound tissue characterization, that doesn't work for the shoulder or the lateral epicondylar region, but does for straight tendons like the patella and the Achilles, I think we're at an unknown crossroads with that.
Right.
Studies are starting to come out that shows it does guide clinical interventions. I think we do need to know in the Achilles whether we're talking, like I said, about some of the fat pad bursal or things like accessory soleus muscle, so a low insertion of the soleus, and we need to distinguish these differences between it and possibly the plantaris that's become sort of stuck into the side of the tendon itself, although in some people it seems to be a normal anatomical aspect. But I know from Alfredson's work that they've reported that the plantaris type disorders don't respond to a normal conservative regime and then go on to require surgery. So I think we need to be careful with saying it's useless, but we don't need to hang our hat on it and say that's what we do because the scan showed this. it's always been clinical reasoning.
Of course, yeah, and everyone, that's the recurring theme with any guest that we've had, is that we're all very pro clinical reasoning. It's what you bring in and how you interpret it that's important. Shall we say into treatment and management? How far do you feel we've come since the traditional eccentric heel drop protocols, and when it comes to common practice, so not just you or I or the people we interact with in Twitter, the Joe blogs who might not be even reaching these podcasts, are they still 10 years behind?
That's a tricky question, isn't it? Because we don't necessarily interact with them as well. When you have a natter with a lot of people, they seem to sort of come back with grossly different stuff. Some people will still talk to you about tendinitis when we talk about a tendon, and they'll talk to the patients about tendinitis, and I'll see patients that have had explanations along that line and had things like ultrasound done and some other very passive responses without using any loading on top of that. It's quite scary, but I guess it's just like any profession. There's cowboys in each profession and people that are just behind the times sometimes, and it's hard to sometimes not get lost, because most of the guys on Twitter are on there for a reason. It's fantastic for learning and developing yourself and actually doing your CPD, finding new research and things. It's been awesome for me in the last year or so. So yeah, those guys are all really good on there. But then if we look at sort of outside and what goes on in other clinics where people maybe don't engage with CPD that frequently, I do think people are doing some stuff that's even older than eccentrics is.
Right.
Eccentrics took a long time to come in, and I know when I was working in some of the bigger teaching hospitals, sometimes we get referrals back from the smaller hospitals and people wouldn't have even been given normal loading, so eccentrics at the time. So it's hard to say exactly what goes on out there without doing a massive national study, which would be a really good one.
Yeah, and I think there is an element of people being blissfully unaware, of course, yes, cowboys, but also people that are blind to it, not not on purpose anyway, shall we say.
Absolutely, yeah. It might not be their area. And let's face it, it's a bit like being a GP. If we're Joe Blogg's physio who works in a normal clinic, just like I do myself, I see everything. I see whiplash, I see your chronic low back pains, I see your acute backs, I see knee injuries and all sorts. See a fair bit of tendons, but not as much as the specialist tendon clinics will. So if you're seeing all those mix of clients, you don't necessarily bother reading about tendons because you might see 3 a year.
Yeah.
So I think, we've got to understand why people don't always maybe do the right thing in our eyes, and not chastise them too much, but just educate the patients and get the patients to move on.
No, lovely. No, that's a really nice way of summarising it. It brings us on to, because we've talked to death quite rightly about the loading profile, we could talk more, but if we said that we know there are interventional treatments for Achilles tendinopathy, and particularly like any part of the body, can become very trendy, become the next big thing. Examples being high volume injections, PRP. We've mentioned corticosteroid now being said, well, Paratenon, we want to make sure we don't go into the body, but
inside the Paratenon as well, I'd add.
Yes.
I think bathing the tendon in it is not necessarily a good thing, but certainly not in it. If it's short acting, people seem to be happier with that.
Is that just the lesser of two evils?
I don't know whether it is or not. It's some big tendon names that have recommended the short acting stuff. I think it's probably got a place, and really it's been recommended, I think, from a elite athlete perspective of getting them through that competition, and you've got other pressures at that stage. So I think it's there in a particular group. I don't think necessarily myself in my little clinic needs to worry about that, because I'm not dealing with the likes of people like Mo Farah or Paula Radcliffe. I'm dealing with Joe Blogg's person.
Not yet.
Not ever, I don't think. I'm quite happy with my group of patients, and that's where a lot of my work's going, really. The PRP and the other sort of blood injections that are done, so some will take a bit of blood, they'll inject the blood as an AB injection, or they'll do the centrifuge and actually do the PRP, so they'll separate out. There's plenty of systematic reviews now that have clearly shown, looking at all the randomised controlled trials, that compared to placebos, it doesn't seem to have any beneficial effect. You'll still get a lot of people that are recommending we do it. I can't recall having heard of any bad responses to it, other than the odd small infection. So I guess there's that. It's better than corticosteroid if you're going to do something. I've just not had a patient that's needed to have any other intervention for a long time, since I was in the hospital, really. And that was often just because we couldn't get to the patient before somebody else got to them and did something else. So it's been a long time since I've ever needed to consider any other option. The high volume injections that's done sort of with Otto Chan and the guys down in London, it looks interesting. We'd probably need some placebo-controlled trials that are sham as well. So we don't need just a fake injection. We need a fake injection with a screen up that shows you the high volume type of injection on another patient. There's a lot of theatre that goes on in it. And if we're talking about acupuncture being theatrical, well, definitely high volume is. But there may be some mechanical stuff. It does seem to break adhesions when you watch it be done and things like this in the parotina. So there's work being done on that. We need to see what happens. I'm not somebody that uses it. I don't inject, full stop. I'm not trained in it. But yeah, it'd be an interesting one, what happens there. I've always got an open mind on everything that's offered, even when PRP first came on the scene. But I'm probably more cynical now than I was sort of 5-10 years ago.
Opening our minds is a very important thing, and discussing those on level playing fields as well. However, when people say things need time to develop the evidence base, they also need to sort of sit within at least parameters that we do take as being towards fact. And high volume does take us, in clinical reasoning terms, back a few years. And do we need, how long do we give it almost, before we start to recognise it might be another fad?
That's a tricky one, really, because high volume definitely changes the neovessels within the tendon. But we also know the neovessels don't particularly relate to pain. Having said that, though, you've got the likes of Håkan Alfredsson, who is world-leading tendon expert, who will do his anterior sort of scraping technique on the tendon, which kills the neovessels. And then you get a bigger response after that. So a few weeks later, there's more neovessels. And that seems to be a good reducer of pain immediately afterwards. As is the high-volume stuff. It seems to get rid of the pain. It hurts when it's done, but it seems to then abolish the pain straight afterwards. So how neovessels relate to pain is probably something we say it doesn't correspond, but what do neovessels go with? Neovessels are there with a nerve, and the nerves are obviously something that can generate pain. And if we look at animal models of ruptures, which are very different from a tendinopathy, but if you rupture, you'll get nerve ingrowth, and the blood vessels go with the nerve to support the nerve. And these nerves release certain chemicals, so neuropeptides and things that will stimulate cellular responses that are your healing response. So whether or not we're just looking at the wrong thing, so we're looking at the blood vessel that's actually with the nerve, and whether we should be looking at nerve content more, which may then link to sensitivity to mechanical loading, especially when you combine it with some of the biochemical changes that we know go on. So like glutamate and the substance P and things, which are neural sensitizers, and they're all released by tendon cells. So there's a lot of complexity in it, and this is where we have the pain science bit and sort of that aspect, but we also have a load of physiology that really sort of then guides us in another way. So I don't know. I do think we probably need quite a bit of time, because I think we need to understand, one, whether they work clinically and whether they work better than sham placebos. And then two, we need to unwrap the mechanism. Because if we apply what we've done to eccentrics have been around since the late 90s in the format we currently use. But prior to that, they were around in the 80s with Stanish and Kerwin. And there's another study that was done back then that looked at Achilles doing a concentric eccentric versus an eccentric only.
Right, okay.
It's not one that's talked about very often and seems to have missed everybody's sort of list, but I think it's Neurogard, I think. Oh no, it's not. I can't remember the lady's name anyway. Verton Bisosen or something. It's on one of the systematic reviews. It's around, and they showed actually the eccentric only was better than the concentric eccentric. But it's only a small study on small numbers and things. And
yeah, they can be hidden accidentally almost, don't they?
Yeah. So I think when we think of eccentrics being around for such a long period, well, high volume is relatively recent. And so, or some of the other stuff. And so we probably do need to give it a fair time. We don't understand why eccentrics work.
Of course.
It's part of the work we're doing at the moment is trying to unravel why exercise therapy may work for tendon management, but we don't understand it at the moment. There's loads of factors like pain processing, neuromuscular function, and the actual tendon itself in terms of structure. And we might have scanners that aren't accurate enough to discern slight changes to tissue hysteresis and things like that. So like the viscoelastic elements, there's some other machines called elastographers, and there's a group that have sort of slightly tweaked one and apparently getting a bit more reliable results and things. So there's loads of bits, and it's just a case of, like you said, having an open mind and seeing what comes out.
So lots of things up in the air, but we've got to be open to integrating them as best possible and discussing them openly. There's less secrecy, it seems, now that particularly with the internet, we can discuss things more openly, and that's only a positive.
Yeah, and I think we need to really just get down into trying to understand why treatments work. I think we need to do a big focus onto actual physical mechanisms, looking at exercise therapy particularly. There's been very, very few studies looking at why, let's say, eccentrics work. And that's really where the focus needs to shift now in tendon management, especially from physios. Yeah,
and I look forward to discussing with you at a later date. We've already got plans to discuss your research in more depth without letting the cat out of the bag too prematurely. And it brings me, I think, nicely back to my very first question, which was why tendons, why TA, is that having discussed things with you, would it be fair for me to say that tendons might be a perfect example of physiology and mechanistics meeting neurology, especially when it comes to in terms of pain? Is that one of the things that gets you or develops your passion to talk about these things?
Yeah, I guess it is. I like my pain stuff. I'm a big fan of the sort of classification-based cognitive functional therapy approach from Peter O'Sullivan and stuff. And I think that sort of ties in very nicely with what we see in tendons and any musculoskeletal disorder. I think you can apply the same thing, but we've got to subclassify to get better results. So for the tendon, subclassify mid-tendon versus insertion versus muscle tendon junction versus any other cause of posterior heel pain.
And with classifications, doesn't necessarily need to be born recipes.
No, and there never are. And if you watch the experts in that method work, they often don't really use it themselves anymore. They've got so good. But I think as physios, we need sometimes to be able to box and compartmentalize a little bit to help us develop a framework, which we talk about in educational terms as well, a scaffold to hang everything else on. So scaffolding is quite important, I think, and sometimes saying, well, you might get a patient like this and that's what they look like, or like this. So we give the sort of textbook presentation, appreciating that patients don't present like a textbook normally, but it gives us a bit of understanding to start working on.
And categorical thinking is human nature, and at least primarily if we start from there, we can easily draw on moving that educational journey forward, and like you said, the experts almost phase out of that, but they had to be there at one point. So I think that's really nice, and I think it brings us to a natural close almost, where I'll give you the opportunity to, tell us where to find out more about you and whatever you like to plug, Seth.
Probably just the geeky Twitter feed that we have. So I think it's just at Seth O'Neill, which is capital ONN. You can have a quick peek on our website, which is on the Twitter feed as well. So it's Achilles Tendon Research.com, all one word. And we'll be hopefully developing that over the next year or so as we start to get our research out a little bit more. Some of it's hopefully going to come out later this year. Other than that, that's about it, I think.
Okay, but you'll still let me come and chat to you when you're a doctor, Seth O'Neill, yeah?
Hopefully. Okay, well, it might be a while till I'm a full doctor, but yeah.
Thanks a lot. And we're sat here in your lovely clinic, and tell us a little bit about that, if there's anyone local or if someone wanted you for a second opinion on something.
I work in Keyworth, which is a small village south of Notts, and we've got a website. It's keyworthphysio.com or .co.uk. They can have a peek on there, and they can contact me through that if they want to, from a perspective of Achilles or whatever else. Most of my work is GP referral and word of mouth, really. I see a lot of runners from around the East Mids that come and see me for tendons and other shin splints and the like, so often having seen other people. So.
Okay, fantastic. And again, thank you very much for your time.
Pleasure.
Much appreciated.
No problems. Thanks, Jack.
And that was session 6. Many thanks to Seth for his time, both in terms of the podcast and for his generosity on Twitter. Seth has shared a wealth of resources with us recently, and all of which will be available by subscribing to the podcast show notes newsletter at choosehealth.co.uk. Many thanks for all interest in the No Pain Meets Choose Health course in Manchester. Due to a schedule clash, it has been moved to the 25th to 27th of October, which also gives us a chance to meet a lot of you beforehand at the Therapy Expo, at which several of our guests are presenting. If we don't take credit for that, they were all a big deal before us, I promise. It's been mentioned to death on this episode that Twitter is an invaluable resource, so please follow at TPM Podcast for updates from the podcast team, at choose_health for rants and musings from me, and of course at Seth O'Neill for gems from today's podcast guest. Talking of Twitter, the man often referred to as the 6th member of One Direction when it comes to popularity, Adam Meekins, has a chat with me about critical thinking, professional progress, and of course the power of social media in next month's session 7. And I shall see you there. But before I go, we will be, of course, having Seth sign us out in now traditional cheesy fashion. Although I swear I hadn't, I initially forgot to record his outro, but by the power of Skype, here it is. I know Seth can bear it when I take all the glory, so I couldn't leave him out. And it's bye from me for now.
You've been listening to the Physio Matters podcast, discussing physio matters because physio matters.